Good evening, dear colleagues, and welcome to our new series of Conversation with Professor Chintamani, where we'll ask him various questions that have been put up by residents and the questions which are often debatable and are asked in various exams. This series has been started on popular demand by many surgery residents who had many doubts regarding various topics in surgery, and we seek answers from Professor Chintamani. So friends, you all are most welcome to put your queries and doubts in the group as well as in the description of the YouTube video so that we can take them up in the next conversation. So we'll now begin with the first episode, and I would like to extend a very warm welcome to Sir. Sir, very good evening to you, and I would like to ask you the first question about the management of axilla in breast cancer. There's always a confusion regarding regarding the dressel of axilla, like in Z11 trial also, where it has been mentioned that if on sentinel lymph node biopsy only 1 to 2 lymph nodes are positive, then axillary lymph node dissection can be spared. So, sir, could you please elaborate on this, whether it is feasible or it is not? The next question that I would like to ask is how much axillary dissection in breast cancer is optimum in patients with axillary lymph node metastasis? And the third question that I would like you to please take up is whether radiotherapy can replace axillary lymph node dissection, and are the results comparable or not? Thank you so much, sir.
Well, thank you, Sukriti. That actually is a very good question, and this is often discussed in most breast conferences. And if you think you found an answer to that, even today I won't be able to give you an answer, but I'll try my best to let you know as to how you should be answering it. So your question is, naturally this patient is a case with an N0 axilla, which means there is no clinically and on ultrasound there is no node, right? So clinical plus ultrasound, this is important to understand because present AJCC 8th edition requires it mandates that you should have clinical and ultrasound assessment.
Yes.
And I don't need to tell you the ultrasound features that would suggest it to be metastatic lymph node, which is spheroidal in shape. There is a hypoechoic area of necrosis in the center, loss of halo around it, and the fatty hilum is replaced by vascular, or yes. So you suspect that these features are present, then it's an N1 axilla. If they are not present, then it is N0 axilla. So you are basically talking about N0 axilla, where they often talk about, since you also mentioned Z11 trial,
Yes,
which was a American College of Surgeons oncology group trial, that is to find out whether there is a select group of patients where we can spare them axillary dissection if on sentinel node biopsy. Naturally, these are cases which are early, so one is doing breast conservation surgery, and since they're N0, they are subjected to sentinel lymph node biopsy. And usually the standard of care has been so far that if it is an N node, it's a negative sentinel node biopsy, then we can spare the axilla. But if it is positive, usually you should err on the side of saying we will be doing completion, that is axillary lymph node dissection. Now this study is about this actually. So what did they actually do in this study? Before I come to that, I'll just touch it once again. The protocol is you have done the ultrasound and the node is suggestive of malignancy with the features that I mentioned, spheroidal, with hypoechoic area of necrosis, loss of halo, and the fatty hilum being replaced. Now this node in good centers would be subjected to core needle biopsy or at least an FNA, and in some centers they will even mark it, core and mark it. That is to, if the patient is to be put on neoadjuvant chemotherapy, you will know this node actually whether it responded to neoadjuvant chemotherapy or not, so that when you go in for a definitive management, you can just take that node out. Well, that's besides the point of your question. I'll just stick to your question. So what they were looking at was First of all, you should be very clear today, unlike in the past where we all believed the lymph nodes actually are the most reliable and significant predictors of outcome. They still are significant, but they are not the most significant ones, because today we are looking at the biology of the disease. So if you have a luminal A cancer as opposed to the luminal B, ERPR negative and HER2 neu positive, or ERPR positive, HER2 neu negative versus the triple negatives, the outcome is different regardless of the size, presence of nodes. But presence of nodes used to be a very reliable and very important marker based on which chemotherapy, radiation, adjuvant therapy was started and the patients were prognosticated. So one thing that people have learned is that this is not mandatory. So you don't need axillary dissection to decide on the treatment of the primary. That's what they say today. I am not trying to undermine the importance of axillary lymph node dissection, because even that is disease. But earlier days, we used to do axillary dissection to stage the axilla. So now, after the B32 trial, it was found out, it was sequence series of trials, B4, B6 and then B32, they found out that it is comparable to SNB, which is sentinel node biopsy, where the morbidity of dissection is less. So naturally you can address the axilla by finding out whether axilla is involved or not, and for that in an N0 axilla the recommendation is that you do sentinel node lymph node biopsy. Now sentinel lymph node biopsy, if it is positive, you should dissect the axilla. If it is negative, you can leave the axilla, spare the axilla. Therefore, the question came that in some patients, after you had done the sentinel node biopsy, the node was positive, and when axilla was dissected, it was a negative axilla except for the sentinel node that was positive. So that's when the futility of this added dissection and the added morbidity, which is the morbidity of axillary lymph node dissection, we all know is lymphedema, which is the major morbidity, neuropraxias, and also associated many problems. They were worse when there was radiation added to axillary lymph node dissection. Needless to say that most of us know about it. So what did they do? They actually recruited, they were planning to recruit more patients, but they ended up getting less than 1,000 patients, and the accrual stopped. And this Z11 trial, famous Z11 trial, actually was under the auspices or the control of American College of Surgeons Surgical Oncology Group, so ACS Onco Group it is called. Now what did they do? They randomized the patients of N0 disease with early breast cancer, that is the patients were up to T1, T2 and they were N0 as I said. They were subjected to sentinel lymph node biopsy, and then they were randomized into those that would, then they found out those that had more nodes like 3 onwards and those that had 1 to 2 nodes. So these ones went for axillary lymph node dissection. There was no confusion about them. But in this group, they randomized them into 2 arms. In one, they provided them with axillary lymph node dissection, and in the other one, they were just left for observation. I'm putting it in crude sense, so please don't argue on this on Z11 per se. I can go at depth of it, but importantly, you should understand the basics. Now, they observed that the survival and the outcome and the incidence of axillary recurrence was comparable, while the morbidity was higher here. Higher, as expected. Here, the morbidity was low, but the outcome was equal. So naturally, it made sense that some of them with favorable biology can be offered just observation rather than dissection of the axilla. So it sounded good, and most people felt that probably you would not need to each time proceed to axillary lymph node dissection in patients in spite of the fact that sentinel lymph node biopsy is positive and the nodes are less than 2. So they are not talking about 3 positive would mean that you're looking at a positive axilla, so they were being very cautious there. Looks simple and looks great and kind of reduces the morbidity, which is quite significant with axillary dissection, and for which the sentinel lymph node biopsy came into being. But there is a flip side to it. There are problems with this prospective randomized control trial. What was the problem? First of all, as you would notice, now the issues I'm saying with Z11. What are the issues? First of all, when you look at the overall profile, the overall profile was better in the no ALND arm. That is, most of them were more than 60 years of age, most of them were ER positive, PR positive, and they were smallish tumors. Do you understand this?
Yes.
Now, so they were supposed to have a good biology, therefore a good outcome. So this could be a confounding variable in the understanding of what exactly was the outcome. The second important thing was all patients underwent actually BCS, that is breast conservation surgery, and received radiation
Right.
to the primary. Now this radiation that they received had something hidden in it which we did not look at initially, that is they all got tangential breast irradiation, which means while irradiating the breast, level 1 and 2 of axilla would automatically come in the field. So to say that this axilla was completely virgin would not be correct. So even those in this arm uh, those even in this arm in this arm um I mean in this arm, sorry, where they were observed, they by default received radiation. This obviously, so they all got radiation. So in this case also the axilla was treated
Addressed.
or addressed. So you can't say that they did not receive treatment for the axilla. So whether you receive treatment in the form of surgery or RT, there shouldn't be a huge difference. So this arm had received radiation. Now the trouble with the other arm, that is ALND arm, is that not only did they receive radiation, but they also had surgery done. So they had, naturally, we know that when you combine surgery with radiation and do it, they tend to have a worse
Increased
outcome in terms of
morbidity.
increased morbidity and increased lymphedema rates, which is what they are looking at and which is what we are trying to observe. So one arm had ALND, the other arm had observation but RT by default. And they said RT by default, so it's a problem. So that's one problem. So the flip side is one was a favorable overall profile being better in the observation arm. see more than 60 years, there is a bias there, and ERPR positive, and therefore they are supposed to behave better. Then all of them received radiation, and tangential beam radiations were given, which effectively by default would cover up. What I'm trying to say is it will take into account not only the breast but also the axilla, because tangent is it occupies a certain area. The breast and axilla both get covered, so that is what would add to the morbidity. And while we are comparing apple to apple at one point, actually it ends up being a comparison between apple to orange.
So both the groups, both the arms, they received tangential radiotherapy by default. So both of them were
No, they were
infused.
treated. They received tangential radiotherapy as a part of treatment, but by default they received a radiation to the axilla.
Okay.
So it was not intended, but in tangential radiation, it will happen automatically because the field will cover up that area, that part. So therefore, by default, you cannot say the axilla was not addressed. In one arm, while we did only surgery, we did surgery of the axilla, that is axillary lymph node dissection. The radiation was already, the morbidity got compounded. In the other arm, we did not do surgery, but still the axilla was
Addressed.
addressed. So the benefits were there, but the morbidity was not there.
Okay.
In the ALND arm, since the morbidity was compounded, so we had the benefits all right, but morbidity was more.
Okay.
So while the advantages were, the benefits were comparable, the morbidity became exaggerated. So it could be a flip side to what you see. That is the second one.
Okay.
And thirdly, it's not applicable to our, they didn't include mastectomy cases. So we cannot include it in most cases where we are doing patient, no mastectomy patients are included. I'm talking about the flip side to Z11 so that you should understand it had weaknesses. One was the accrual, because they were supposed to recruit 1900 patients, they got somewhere around 900, and the centers that they recruited from were 1200. So you can imagine there were some centers that did not give even one patient. So it wasn't exactly a very robust randomization. And the fourth point was, which was also important, is that there was no control. There was no control over what chemotherapy they received and what endocrine therapy they received. So that also would be variable, and because most of the time the chemotherapy was believed to act only on the, uh, I mean, primary. That's what they felt, but we now know that it acts on the axilla also. So maybe the arm where no axillary dissection was done, since they received chemotherapy, the axilla was addressed automatically. So not only did the radiation address it by default as a part of treatment for the primary in the form of tangential beam radiation, there was no conformal radiation at that time. There was no image guided or accelerated partial beam radiation. I mean, it was a whole breast which was irradiated by tangential beam. So tangential beam effectively would take axilla also. You can't avoid it. It lies in that region. So they got radiotherapy, and you're trying to say that no axillary dissection was done, but the outcome is very good and the morbidity is less.
Right.
The advantage, it is very obvious now. There's no rocket science in it. So there's a flip side and weakness over it. And now, since there was the other similar default, since there was no control over chemotherapy, we don't know if the chemotherapy was contributing to their outcome, and we are constantly counting on surgery and radiation compounding the morbidity of. So effectively, there was an ALND plus RT group, and the other one was just the RT group. So this had more morbidity
Expected.
expected, this had less morbidity which was expected, and outcome was comparable.
Yes, sir.
So it was concluded that you can spare the nodes. Now people worked on it after that, and it's not totally out of context. I mean, it's not totally wrong to believe that we can do it with no ALND. So your question is not out of place, but then you naturally need to. There's a 10-year follow-up following that, more publication in JAMA, where this was a study which was done by Giuliano, and the the whole idea is to reduce the axillary dissection rates. Now, no LND can be offered to select group of patients. That's what you can infer. So, taking the good thing out of it. So select group includes those who are good cancers, small cancer. First of all, they are all small, HER2 new, negative. So good cancer, elderly, and small tumors, T1 bordering T2. So you can spare. So they worked on it. How do you find out which is this group? Now that's how came the role of key 67. Let's look at proliferation index. If it is less than 14% and you have you have this other factors there, that's right. ERPR positive, HER2 new negative, and key 67 less than 14%, and the patient is more than 60 years of age, elderly, it is T1, T2 cancer, maybe we can spare it. So they looked at what can we do to get the best outcome, and you can do a risk stratification with the best assessment. So that's how came the role of Oncotype DX. So nowadays, if you are in a developed country or if you have the money to spare, because Oncotype DX takes about 1 lakh some money, 1 lakh rupees and beyond that. So theoretically, your answer could be if it's an ERPR positive and HER negative in a more than 60 years, you must be wondering, I'm repeating it again and again, with a key 67 less than 14%, you can subject them to Oncotype DX and have the assessment done to find out the low risk ones, spare them the toxicity of chemotherapy, because you would know ERPR positive tumors don't respond to chemotherapy anyway. And in any case, when they're small tumors, and we have done K67 also can be spared. So this is one that select group. So to take the best out of it would be this. But as of now, if you're answering in the exam, if it is a sentinel node, central lymph node biopsy positive tumor, an axilla, we should do ALND to complete it. That's your answer in the exam. But if the examiner is asking you or somebody is asking or you're in any case in practice using it, because everything you should not study just for the exam, you should study for life. You'll have to manage these cases. So if you're looking at it, you should be prepared. And do you know that there are other alternatives available? So if you're asked, and if you can talk about Z11 now that I've spoken to you about it, with its weaknesses, there are more weaknesses to it, but overall you can make out that it's not a robust randomized control trial, so you cannot be very sure. You cannot swear by it. But your answer is, I'll do LND if the node is positive. If they say no, but the patient is 60 years old, ERPR positive, it's a good cancer, it's key 67 less than 14%, 7% or around that, can't you spare chemotherapy? The answer is yes, we can. We are using the Indian panel these days, and I rely on ERPR. I can use it, HER2 and K67. These four markers indicate very well in some select patients, and especially when the patient is not too keen, we discuss it in the MDT and we take a call. So that's the answer to your question. I hope that answers it.
Yes, sir, it does. Thank you so much, sir, for making this complicated trial so easy to understand. So there's one more question which I would like to ask. That while doing axillary lymph node dissection, should we remove all the level 1, 2, and 3 lymph nodes, or there are some books which mention removal of only level 1 and level 2? So what would be the correct approach?
That's a good question, Sukriti, again, and for the benefit of all. We discussed it during scope also, and many times I've spoken during the discussion on axillary lymph node dissection. See, first of all, understand, why this question. Uh, when you talk about the boundaries of axillary dissection, boundaries you should know first of all. We take the medial limit as the Halsted ligament. You can watch. You've seen my videos and you've seen me operate also. So you see that we go, this is the vein. I'll make the vein, that's the axillary vein. the Holstered ligament, and we have the muscle, pec major going on top, and minor here. That's the muscle, pec minor, and we loosely take just this as level 3, behind it is level 2, and this is level 1, and that can change with the positioning. So we rely on landmarks like lateral thoracic vessels here, Holstered ligament here, and right, this is where the level 2 ends. This is where the level 2 ends. And level 1 ends at this, the thoracodorsal pedicle, just here down. And the angular vein here, joining it makes it
Subscapular vein.
subscapular vein. So that's the limit of our lower limit of our dissection. So basically, we are doing the dissection in this entire plane below the axillary vein, and that's Letzmann's dorsi. And that's Letzmann's dorsi muscle. And this is subscapularis, over which this pedicle lies, which we, so that's, so we, the clearance is basically the entire field here. This is all cleared. Now the question that you're asking is in this context, that's why I drew this. Do we need to go up till here or up till here?
Yes, sir.
Now to that, when we teach this to our students, I've taught you too, that is Holstered ligament becomes my medial boundary. And I don't have a confusion about Holstered being my boundary. And so that's Holstered ligament here. So it's kind of drawn costoclavicle ligament. So that's my entire area of interest. Now, you should understand the background to this question. That's the more important. If level 1 is negative for nodes, the chances of level 3 being involved are less than 1%. So logically you would say, why dissect all the time if level 1 is negative? So in those select patients you can spare level 3.
Interesting.
So that's one way to answer it. So if level 1 is negative, level 3 won't be positive in more than 1%. But we have our own data, and we have found that level 3 positivity rates are higher in Indian patients
Due to the disease burden.
due to the disease burden, and also the fact that we cannot for sure know if level 1 is negative. This is a gross finding, we can't rely on it. So we did a study, and we are just going to publish that. When we always send our levels, the lymph nodes separately. So we are just trying to find out how many times we found level 1 positive, level 2 positive, level 3 positive. Or is it possible that we have this positive and this is negative and this is negative, this is positive? It has happened. So I would still recommend a classical level 1 to level 3 dissection, barring a very low burden disease. But then I am also training residents, so I train them into doing a good level 3. This would ensure a good level 2. You get that point?
Yes, sir.
Because sometimes people, in an attempt to do level 2, they do it less than 2 and they end up somewhere here because they're going this way. Our technique is totally different. We start with level 3, you have seen it.
Yes, sir.
And you assisted also in many of these. We do level 3 first, level 2 then, level 1 last, and we come out of here. These endpoints we establish and show because we are very much worked up if the lymph node dissection is not complete, not proper. And the optimal lymph node dissection, you must get at least 10 nodes for any effective decision making. Now, why is that important? Because even lymph nodes need to be looked for lymphovascular invasion, extra capsular spread, how how much they are destroyed, what all is involved. I mean, this is necessary, and angiogenesis in the lymph nodes, everything is important. Even they are good prognostic markers. I still feel lymph nodes are good prognostic markers, although now from the primary itself you can get all the information and you don't need to. Earlier, the axillary lymph nodes this gave us the decision about radiotherapy and chemotherapy in these patients. Well, this has changed because we are treating the biology now rather than the TNM stage. So few things have changed, but I still feel one should clear up to level 3. I have given you the background as to why we do up to level 3.
Yes.
And if you're training your residents into doing level 3, level 2 would happen automatically, and that would really help. The other thing is, if if one is thinking of achieving a disease-free patient, then axilla should be cleared, and we do see axillary recurrences which are worse than the primary. I mean, inadequately done axilla is worse than touching it. You might as well leave it. So if you don't do 10 notes, at least you've done a poor job of it. They come back with recurrence. With the old teaching of 3, 4, 5, that is grade 3, and
Full
4 lymph nodes out of 10,
size.
and size 5 centimeter, usually they will require radiation. So this rule of thumb is quite handy, but it's not true in all the cases. You can even in 1 to 4 nodes nowadays they are giving it. 1 to 4 also. They look at various other factors for X-ray radiation. The chest wall radiation will be given to most patients with more than 5 centimeter tumor because it will fall into the category of locally advanced breast carcinoma. So that I hope should clear the doubt. I mean, if the level 1 is negative, level 3, even if you're spared, it doesn't cause much of a trouble. That's what the data says. We have observed that there is a difference. For training purposes, if you do up to level 3. Now your question can be, if you're doing level 3, does it increase the lymphedema rates? In studies, they say yes, but we don't see that happening in Indian patients. And let me tell you, the properly done ALND compares very well uh, with radiation. In fact, it is superior, although there are studies to show that after 10 years, the lymphedema rates are higher in patients where we have done ALND and they've also received radiation versus only radiation to the axilla, which should not surprise us. Although the radiation oncologists would swear by it and say radiation is a much better more approach, I personally think the surgery is a much less morbid uh, therapy for axilla, and then it will help you stage the axilla, which, as I said, is a controversy. People say may not be required, but for you to answer in the exam, axilla is still a prognostic marker. Presence of nodes means a poorer outcome. So it's very important to dissect to know whether they're positive or not.
So, is there any select group in which, like post neoadjuvant chemotherapy, do you choose to not do the level 3 lymph node dissection?
The answer is no. If I put the patient on urgent chemotherapy, we have even done sentinel node biopsy in these patients to validate sentinel node biopsy in this group. But when I'm doing axillary dissection in post NACT scenario, I will be going up to level 3. Like I said, we go always up to level 3 in all cases. Somehow that's the training we imparted on our residents. But can we spare it in a select group? Your question, post NACT, the answer is no. But in an upfront surgery group, in some patients you can spare it. Definitely, good. I mean, elderly patient with a good cancer, with a very slow progressing tumor, luminal A, and generally good, you may do it. But by and large, we do up to level 3.
Thank you, sir. Um, So there is one more question. Can radiotherapy be an alternative to surgery in case of axillary lymph node metastasis?
Sukriti, there is a trial which is, there are many trials. Amorous trial is one where um, Amorous, sorry, Amorous trial. Yeah, that's a good question because it is believed that if you just give radiation, why not give just radiation? Why subject them to surgery? And this trial stands for after mastectomy, axillary radiation or surgery. And they observed that the axillary recurrence rates are almost equal and the lymphedema rates are more in surgery. That's what they mentioned. They are of the opinion that it can replace surgery. But I'm telling you there is a flip side to it. The selection of patients can be an issue, and radiation you can never know. When axillary recurrence happens following radiation, surgery can be very taxing, and you can actually have a lot of desmoplastic reaction, and if you have decided to address axilla and you know how to dissect axilla, because that's a major question. When these studies happen, a lot of times it is in a scenario where the cancers are very small. Mind you, Ambrose trial, the UK patients are mostly images. We are treating lumps. So don't get confused on the burden, because there the chances of axilla being positive are very, very low. To the extent that an average trainee in UK may not be exposed to axillary lymph node dissection at all, because even his chief doesn't get to do it. And I don't blame them. If you don't have axillary nodes, why should you do it? So they have a good reason for not learning it. But that's not our case. Our average tumor size is 4 centimeters plus. And majority, more than 50% patients have axillary lymph nodes. So it doesn't apply to us. So whenever you are replicating a UK trial or American trial, you should remember my old code. What is that? Can you repeat it? Indian
Solutions to Indian patients.
to Indian problems,
To Indian
not
problems.
patients alone. So you should not look for the Western trials to satisfy your, to be replicated, because most of our patients, I'm repeating, node positive. Most have advanced disease. Most would need ALND. But even in India now, patients are coming with some patients are coming, especially for the students who are working in corporate centers. They may claim that they get to see patients with opportunistic screening, which is a screening done by the patient himself. Patient gets investigated and they are node negative, or elderly, or otherwise not too keen, and you're just on lumpectomy, you can subject the axilla to radiation. As of now, your answer in the exam, standard of care is axillary dissection, because I personally would not emphasize, because the evidence is for both being equally good and one being more morbid than the other, but it is preferable to dissect the axilla. When you are asked this question, you can definitely say that there is Amorous trial, which is, I'm repeating, after mastectomy, axillary radiation or surgery. They feel you may not do surgery at all. And one shocking thing that you observe these days is all adjuvant, all adjuncts are becoming more and more aggressive, and surgery is becoming less aggressive. I think surgeons also, which is good as long as it is benefiting the patient, but we should not go overboard. But there are trials to show that radiation is as good. But naturally, they are again, I'm repeating, they're talking about node negative axilla. It's not that nodes, no, even in MROs, after mastectomy, they are taking mastectomy patient because Z11, if you remember, did not take
Mastectomy patients.
So basically, they are finding the radiation can be a good replacement for X-ray
Axillary
surgery.
resection.
But theoretically, yes, practically today, if the node is positive, the axilla is positive, or the advanced tumor, we should do axillary dissection. I hope
Thanks.
that answers it.
Yes, sir, it does. Thank you so much, sir. These questions are often asked in the examination, and you have made them so easy for us to understand. Thank you, sir, for your valuable
Anytime,
time
anytime. Most
and
welcome.
also for sharing your knowledge and wisdom with all of us. Thank you, sir.